Jackson had an absolute, total, and thorough inability to sleep.
I'm here to get justice for Michael Jackson.
Your Honor, I'm an innocent man.
He was not an anesthesiologist. He was not board certified in cardiology. Conrad Murray was not board certified in any medical specialty. Michael Jackson's death was a homicide.
Placing the balloon pump was very smooth. One stick and we got into the artery and we placed the balloon pump. But as we suspected, it didn't achieve anything. It couldn't bring back life.
Okay. And to be clear, Dr. Cruz was the attending cardiologist?
Yes.
Okay, and you were working under him essentially?
Yes, I was the fellow at that time, and Dr. Cruz was the attending.
Okay. And after the attempt was made with the balloon pump without success, was it shortly after that that pronouncement of death occurred at 2:26 p.m.?
Even before the balloon pump placement, we made an agreement with Dr. Murray that this would be the last attempted procedure on Mr. Jackson. We'd like to prepare Dr. Murray mentally to accept the fact that Mr. Jackson could not be rescued and would allow Mr. Jackson to depart in peace and with dignity. So we propose that if this would not work, we would call it stop.
Okay.
We would not try other procedures.
And is that what happened?
Yes.
Okay, and he was pronounced dead shortly thereafter?
Yes.
And again, during these ongoing conversations up through and including these conversations about the balloon pump, did Dr. Murray ever once mention administering propofol to Michael Jackson?
No.
Thank you. Nothing further, Your Honor.
Mr. Walgren, thank you. Cross-examination by the defense. Mr. Flanagan?
Dr. Nguyen, what time were you called to come to the emergency room?
Shortly before 1:35, because I remembered that when I was seeing Dr. Murray and talking to him, I looked at my pager and noticed that the time on my pager indicated 1:35.
Okay. How long before 1:35 were you called?
A minute.
And where were you when you were called?
I was in the rounding rooms of the cardiac critical care unit on the 7th floor.
When you arrived in the trauma unit, who's the first person you talked to?
Dr. Rochelle Cooper, but only to say hi, and she immediately pointed to Dr. Murray and introduced me to Dr. Murray.
May we have just a moment, please? We're going to give you a cup so you can have the plastic container below you, because it may interfere with the sight line. That way you'll have the water. If you need more water, you let us know.
Thank you, Judge.
Thank you.
Thank you.
I'm sorry for the interruption.
So the only conversation you had with Dr. Cooper was to say hi.
She immediately said, that is the physician for Mr. Jackson, Dr. Murray. She introduced us. That's about it.
How have you been notified to come?
She asked, she paged me.
Okay, so when you walked into that room, you didn't know who was there.
No, I knew who was there.
How did you know?
When she requested assistance, it was a code for a VIP patient named Michael Jackson. So I knew that Michael Jackson was down there.
So when she paged you, she told you it was a VIP named Michael Jackson.
Yes.
And so you went in and you didn't ask Dr. Cooper what the situation was or anything?
No, I asked Dr. Murray first.
Why would you ask Dr. Murray first?
He's the primary source.
Wasn't the doctor in charge, Dr. Cooper?
I will talk to her next. That's the plan. But this is not atypical for a case that the CCU service was requested and there was EMS still there. I always went to the source first and then went back to the UCLA attending physicians and nursing staff.
So
later.
the first information you got on this case, relative to what was going on, was to talk to Dr. Murray.
That's correct.
And he told you that Mr. Jackson was having difficulty sleeping and had called him to his bedside to give him something to go to sleep.
He didn't say call to the bedside. He said Mr. Jackson had difficulty sleeping. He was tired from the preparation, practice, rehearsal for the concert tour in England and asked for some sleeping aid to help him sleep. But he didn't really say the word called him to the bedside.
Okay. So Mr. Jackson had asked him for something to help him in sleep.
Yes.
And Dr. Murray told you that he had used lorazepam.
Ativan 4 milligram IV was his exact words.
Okay. Did he tell you that it had been given in 2 separate doses of 2 milligrams?
No, he did not.
Did he tell you that he'd also had Valium?
No, he did not. Actually, he answered negatively to my question as to whether there were any sedatives or narcotics involved.
Did he tell you he'd also had Flomax?
No, he did not say that either.
Okay, so, but you know that Dr. Murray told Dr. Cooper about these drugs, don't you?
I did not know that at the time I was talking to Dr. Murray. No, I did not.
Well, you know now, though.
Yes, after the fact.
And Dr. Cooper had been told the 2 milligram doses, correct?
She might have not. I would not be able to tell.
And after he told you about the Ativan, 4 milligrams, he really didn't give you any other information, did he?
No, he did not.
You asked him when he'd given it to him. He said he didn't recall.
Correct.
And you asked him when he noticed that there was an arrest. He didn't recall.
He did not recall the time.
And you asked him when EMS or the emergency medical services arrived.
No, my question was when did you call EMS, not when the EMS arrived, I believed.
You didn't, this report here, I guess you didn't write this investigation report, did you?
I did not write an investigation report.
Okay. So, if you were quoted by the police officers who took your statement that you asked him when EMS arrived at the scene.
Now, being a cardiologist, are you also certified to use propofol?
Yes,
You use it from time to time?
I used it, but you mean how do I tell that the patient has reached the desired effect, going to sleep calmly so that we can start the procedure?
What can you observe in a patient to determine whether the patient, the propofol is active and has worked?
I was not responding to verbal stimuli.
Okay. You don't talk to him, do you?
The anesthesiologist that would be assisting us during the procedure would be responsible in determining that the patient has reached the state of sedation that we could proceed with the procedure.
When the patient is sedated under propofol, they're not talking, are they?
They're not. No.
And you never hear slurred speech from a patient under the influence of propofol, do you? Now, so when you were talking with Dr. Murray, did you make any assessment as to his demeanor?
Dr. Murray's demeanor?
Yes.
He sounded desperate, and he looked devastated.
You came up, you introduced yourself, asked him what happened, and you could tell at that particular point in time he was desperate and devastated?
During his conversation with me, I was not able to make that impression before I started talking to him.
Okay. But when you talked to him, it was clear this guy's devastated.
Yes.
And while you were talking to him and in his devastated state, he told you, please, doctor, don't give up. Is that correct?
Do not give up easily. Please try to save his life.
Okay. But he didn't recommend this balloon pump, did he?
No, he did not mention those words in particular. No.
Because in actuality, you quickly became aware that there had been no pulse on this patient for over an hour. Is that correct?
There was no pulse. Whether it's for over an hour or not, at that time, I couldn't tell.
There had been no pulse since his arrival at the hospital, had there?
I was not present when he arrived at the hospital. He was taken care of by the emergency room team.
Okay, but before you decided to do anything, you checked with the other doctors, probably Dr. Cooper, and asked Dr. Cooper, has there been any pulse?
That's correct.
And she said, he hasn't had a pulse.
That's correct.
And as a matter of fact, did she tell you that she wanted to call it when he was at his home being treated by the paramedics at 12:57? Did she tell you that?
I only knew that after the fact.
Oh, she didn't tell you that before you started making your diagnosis?
No, sir.
And she didn't tell you that she learned from the paramedics at 12:26 that there was no pulse?
No, sir. Actually, I was under the opposite impression when I was called to come down and assist. I expected the patient to have been, the patient was coding. That's what I was told. That means that resuscitation effort was at least partially successful, and either I had to help with some procedure and get ready for admission to the CCU.
But when you got down there, you saw the patient, there had been no change in the patient's condition since he arrived there in the emergency room.
Since his arrival or not, I would not be able to tell right at that time. All I knew was the patient, by the time that I came down, appeared lifeless. I couldn't find a pulse. My attending couldn't find a pulse.
Okay, now, when you have a patient there that has no pulse, there's no indication to use a balloon pump, is there?
Not typically, no.
I mean, in an ordinary situation, when you come down and you find any kind of a patient, the patient's not breathing and has no pulse, you're not going to use a balloon pump, are you?
No, unless there was a physician or a nurse trained in knowing how to take pulse, such as Dr. Murray, that claimed that he got a pulse. We gave him the benefit of the doubt.
Well, at Dr. Murray, did somebody tell you that while Michael Jackson was at UCLA Medical Center, Murray had got a pulse?
Dr. Murray told Dr. Cruz that he got a pulse.
Since he was at the medical center, he was never even allowed to touch Mr. Jackson, was he?
I was not aware of what he was allowed or what he was not allowed.
Did Murray?
Well, allow me to finish. You may.
But during the time that I was present there, he did not touch the patient.
And all of the other medical people there said there was no pulse, correct?
Correct.
Now, did Dr. Murray tell you that he felt a pulse?
He told Dr. Cruz.
Who?
He told Dr. Cruz.
Dr. Cruz?
Yes.
Okay. Did you tell him when he felt the pulse?
Dr. Cruz probably did not ask when that was. I learned from Dr. Cruz that Dr. Murray told him that he found a pulse Dr. Murray requested that we did not give up on him, so we would go ahead and put in the balloon pump.
Okay, when was it that Dr. Murray felt the pulse?
I did not ask because Dr. Murray didn't tell me. And specifically, he told Dr. Cruz.
Did Dr. Cruz ask him when he felt the pulse? Whether it was an hour ago or 2 hours ago?
Not to my knowledge.
Would it matter if it was an hour ago or 2 hours ago?
In a case of collapse like this, we're not talking about hours, we're talking about seconds, minutes.
So...
Yes, it matters. It matters very much.
Now, you indicated that you did it... well, first of all, was it your idea, Dr. Cruz's idea, to do this balloon pump?
It is Dr. Cruz's idea after conversing with Dr. Murray to proceed with the balloon pump for the two reasons that I just cited. Number one, Dr. Murray found a pulse. Number two, Dr. Murray requested that UCLA did not give up easily and try to save his life.
Okay, now, you used the term good faith a little while ago. Is good faith a medical diagnosis?
Not to my knowledge.
Is it an indication for treatment?
No.
I mean, there was absolutely no reason whatsoever to do a balloon pump, was it?
There is no indication if there's no pulse. If there's a suspicion that there can still be a pulse, then the indication still exists.
And when you've got... What time did you do this balloon pump?
I could not remember. Could you go back to the record and remind me? But it was maybe, if I had to guess,
Well, don't
5.
guess. You can estimate, or else you can go to the next step.
This is my estimate. 5-7 minutes. As soon as we got the equipment, we put it in. I think that it's 5 or 7 minutes.
When
That's
did
my
you get
guess.
the equipment?
Our CCU charge nurse brought it down
Okay, when did that happen?
right away after the
What time?
5 or 7 minutes is my guess. I don't have the record in front of me.
So what? The only time you really know about is 1:35.
1:35 was when I started talking to Dr. Murray.
Because at that point in time, you looked at your pager.
That's correct.
And other than that, you don't know any times.
No.
Just a moment, please. Sustained. It's argumentative as well. The answer is stricken disregard. We ask,
Do you know any other times other than the 1:35?
I could give you an estimate of time interval as to when we put in the balloon pump, and there was a time of death that we called.
When did you put in the balloon pump?
About 5 or 7 minutes after the agreement to put in the balloon pump was reached.
What agreement?
The agreement with Dr. Murray, Dr. Cruz, and I that we're going to proceed with putting in the balloon pump in a desperate attempt, even though very much futile, to try to bring back Mr. Jackson to life. If this should fail, we would call it quit and call it that time of death.
Okay, now, did Dr. Murray participate in this agreement?
The agreement was made with Dr. Murray, so Dr. Murray participated in the agreement, and he kept his word. And when the procedure showed to not be able to reach its desired miraculous effect of bringing him back to life, everybody agreed to call the time of death, including Dr. Murray.
Okay, now, so prior to putting in the balloon pump, you went to Dr. Murray and asked him if he'd agree that there'd be no more procedures if you used the balloon pump and it didn't work?
Yes. The agreement was made very clear, not only just to Dr. Murray, but to all the personnel present in the ER room at the time.
Okay, and who posed this agreement?
Could you repeat the question?
Who put forth the terms of this agreement?
The CCU team, and that means Dr. Cruz and I.
And so basically what you said to Dr. Murray is, hey, look, we're going to try this procedure. It probably won't work. But if we do that, That's it. We're going to call it.
If we do that and it fails, then we need to call it stop.
Okay.
Yeah.
Now, what did Dr. Murray say in response to that?
He agreed to it. Yes.
When you say he agreed to it, what were his words?
He said yes. The word is yes.
Okay, so you told him what the conditions were, and he said yes.
Yes.
But the balloon pump wasn't his idea at all.
No.
If I could have just a minute, Your Honor. And after talking with Dr. Murray, you went back and talked to Dr. Cooper. Did she then tell you the other drugs that Dr. Murray told her about?
I did not ask Dr. Cooper as to other drugs being involved or not.
Okay.
That was one thing that I omitted.
Now,
Yes, I did ask Dr. Murray in my earlier conversation whether he attempted to use anything to reverse the effect of Ativan.
what would be appropriate to reverse the effects of Ativan?
Flumazenil.
How much?
Just give low 1 milligram or something like that and started
The insert calls for 0.2 milligrams, doesn't it?
0.2 milligrams, yes.
So that would be the appropriate dose to give.
Yes, it is more the time. The purpose of using that was as soon as the patient was down from Ativan, to use that to prevent the further depression of the brain state,
How
to
fast?
prevent or delay the need to put the patient on the ventilator.
So how fast after the patient stops breathing should it be used?
Immediately. We're
Okay.
talking about seconds. Immediately.
What is your window there? Would a minute
Seconds.
later be too late?
Before the placement of the patient on the ventilator, the hope is to delay, to buy time, to get the equipment ready to intubate the patient.
So if a doctor feels that the patient is suffering from the effects of Ativan, lorazepam, the appropriate procedure would be to IV inject 0.2 milligrams of flumazenil.
Yes,
And
repeat the dose if it didn't work, but it has to be fast. The point is to try to reverse it in order to delay or not having to go to the need of intubating the patient.
And how long? I've heard your previous testimony talk about window of opportunity. You know, time is of the essence.
Yes, sir.
How long from when the patient has a complication from lorazepam, how long does that window of opportunity last where you can achieve something by injecting 2 milligrams of flumazenil? 0.2, excuse me. Thank you, Your Honor.
We're talking about seconds to minutes. And the reason why I said time is critical, time is the essence, is because it means a drastic difference between 100% chance of recovery with minimal neurological impairment, meaning we could totally reverse this, especially when the patient has never been diagnosed with any chronic illnesses of the lungs, the heart, or the liver, or the kidney.
Impairment, meaning we could totally reverse this, especially when the patient has never been diagnosed with any chronic illnesses of the lungs, the heart, or the liver, or the kidneys. It is totally reversible, 100% chance reversible get back to life at baseline with minimal impairments to 0% of recovery. But Ativan, as I said, did not typically do that. They do that sort of effect, causing severe respiratory collapse. It does not cause cardiovascular collapse. It can cause the patient not to stop breathing because it depressed the brain state so much that it could do that.
So my question was, I asked you, how long is the window of opportunity where flumazenil will be a good solution?
As soon as we found the patient down and we know that the patient has Ativan on board, and that's when we use it. Use it right away. As with any narcotics or sedatives that we use, if that sedative has an antidote, the antidote has to be available at hand for immediate usage.
I know. You want to use it right away.
Yes.
My question is, how long is the window of opportunity where there is a good chance at success by using it?
Minutes. Seconds to minutes.
Okay. Give me a number of seconds to a number of minutes.
It depends on the dose and how it was given. If you gave Ativan 20 milligram IV, as you mentioned earlier, that window of opportunity was very small for you, and 0.2 milligram of flumazenil is probably not going to cut it.
Okay. I'm asking you, not small or large or minutes to seconds. I'm asking you precisely from a point in time, what is the range? What is the window of opportunity where it would be successful?
After you administer flumazenil, how do you going to tell that it is successful? Am I understanding you?
After you've detected that the Ativan or the lorazepam
Yeah.
has caused a problem, and the patient, say, ceases to breathe, how long is that window of opportunity where you could successfully use flumazenil?
Minutes, sir.
How many?
2, 3 minutes.
Okay, after 2 or 3 minutes, the window of opportunity ceases and you can no longer achieve a desired result with flumazenil.
Correct. Probably the next step or the concurrent step is to get anesthesia to get ready to intubate the patient.
Okay, but after 2 or 3 minutes, you're not going to, flumazenil's just not going to work.
It's not that it's not going to work, but you are wasting time instead of preparing for the next step.
Oh, so if you don't get the flumazenil in within 2 to 3 minutes,
Yes,
the next step is to intubate.
because the patient is progressing to respiratory depression now and would need breathing support, being put on a ventilator, things like that, and that would require assistance from the anesthesia staff. So if 2 or 3 minutes pass by and flumazenil was still not around there, concurrently, actually, when we ordered flumazenil to be brought by the nurse or assistants, we had to get anesthesia to be on board with us. So if flumazenil came on time and achieved the desired effect, we may not need to intubate if the patient already woke up. If not, we would have to proceed very soon. So it was just minutes that we're talking about.
Am I correct in assuming that with 4 milligrams of Ativan, you wouldn't expect to have an event that required flumazenil, would you?
Not really, especially for a patient that has been so used to taking it. Now, if you use it on a really small, frail, petite lady for the first time, she's never been exposed to it, you may see that, but not in a person that has been accustomed to that sort of dose, because his drug tolerance would be a bit higher.
So a person that's somewhat tolerant to benzodiazepines, 4 milligrams of Ativan, you don't expect any complications, do you?
Overruled. Do you understand the question?
Could you repeat the question again?
So if you have a person that's somewhat tolerant to benzodiazepines, has been using them over a period of years, you wouldn't expect 4 milligrams of Ativan to cause a problem like that would require flumazenil, would you?
No. Let me clarify the question, because from what I hear the question, it looks like there is two stands to it. Would I expect a problem from 4 milligram Ativan IV? By problem, I assume that you say cardiovascular collapse and respiratory collapse. As I mentioned earlier, Ativan shouldn't cause cardiovascular collapse. It can cause patients to stop breathing, however, especially with large dose. Now, would it require flumazenil? If you see a patient is down and Ativan is the only thing, or other benzodiazepine is the only thing on board, use it. What do you lose? Use it while you're buying time to get the patient to be ready for intubation. But 4 milligram IV Ativan, we could use that for procedure, and I've never seen that we had to go to the need of using flumazenil to wake the patient back up or having to intubate a patient after just 4 milligram of IV, even though it is a moderate dose. It is not a large dose.
If I could just ask you, I kind of get lost in the answer. The question I really wanted to know is 4 milligrams of Ativan in a person who's accustomed to using benzodiazepines, you wouldn't expect that to cause cessation of respiration, would you?
Not typically, even though anything can happen, not typically.
Okay.
But we always use it under monitored setting with oxygen on board.
Well, Ativan's frequently used in an unmonitored setting, isn't it?
IV?
What's that?
Vague, if you mean in the hospital?
Well, I think you have to go into the particular source of administration, whether it's by mouth or by IV. Sustained on that ground. Re-acid.
Ativan is taken orally, isn't it?
It's administered in many ways. It can be taken orally. It can be administered by IV.
And your first preference would be to try and use it orally, wouldn't it?
Let me clarify. My preference would depend on the indication. I don't typically use Ativan or any other sedatives or narcotics to treat insomnia. There are other drugs available. But I do use Ativan for procedures. Yes.
One of the indications for Ativan is insomnia, though, isn't it?
That's correct.
Okay. Now, nothing further at this time, Your Honor.
Mr. Flanagan, thank you. But a redirect examination, Mr. Walgren.
Thank you.
Thank you.
Dr. Nguyen, you have specific privileges at UCLA to utilize propofol when appropriate?
Yes, I do.
Okay. But you use an anesthesiologist when you do it?
Yes, I do.
Okay, and this is for what type of procedure?
Typical procedures that we use with propofol is direct current cardioversion, meaning if patients have an abnormal heart rhythm, such as atrial fibrillation, we would like to reset the heart back to normal sinus rhythm, and the patient has not failed some drug treatment. One way to do this, to use a current to shock the patient and bring the heart back to reset the heart rhythm back to normal sinus.
And when you do that, so you would be present?
Absolutely. Many people are present.
Who would be present as far as medical personnel?
At least a cardiologist attending, at least an anesthesiology attending, and resident or fellow, at least a nurse. So at least 3 people.
Okay. And in this type of situation where propofol is being administered, this would be in the hospital setting?
Always in the hospital setting. And it's just not any hospital bed or room. only in the ICU of the procedure room. So it is not anywhere in the hospital. It is designated place with designated personnel and equipment available. By equipment, I mean a crash cart should be available. Why did we need personnel such as anesthesiologists, even though I could administer propofol? That's because in case that we overshoot the threshold of tolerance by the lungs, because unlike Ativan, propofol certainly could cause severe respiratory collapse and cardiovascular collapse, and there was no way to know what is the tolerance threshold to achieve the desired effect versus the threshold that the lungs or the heart could take. If we exceed this toxicity threshold while we still have not reached the desired effect, then we are in pretty bad shape. That's why we need anesthesia. That's why anesthesia is involved, and there's always a crash cart inside the room.
And what does the crash cart have?
The crash cart typically has ACLS drugs, similar to the drugs that EMS arrived on the scene when a patient was collapsing, and they could administer epinephrine and things like that. It's all within the crash cart. It has a defibrillator. Actually, we already had the defibrillator out, ready to run.
Okay.
Yeah.
And in the setting, you'd have all the monitoring?
Absolutely.
Heart monitor?
Yes.
Capnography, pulse oximetry?
Yes.
Okay.
Yes.
You'd have all the emergency airway equipment?
Yes.
Okay. And you had indicated when Mr. Flanagan was asking you about lorazepam and flumazenil, you indicated what you really should be doing at that point is proceeding to the next level and ventilating with the endotracheal tube, correct?
Yes.
Okay. And of course, in a house setting, if you didn't have an endotracheal tube, that's not an option, correct?
In the hospital setting, especially in the CCU, that's a mandatory equipment. We never would be in the situation of not having it.
Okay. So you would not oversee or personally administer propofol without having the equipment I've listed off, including the emergency airway equipment?
No, sir.
That's a correct statement, what I said?
That's a correct statement, what you said.
Okay. And regarding the balloon pump, you indicated one of the reasons you proceeded with the balloon pump was to give Dr. Murray the benefit of the doubt, and by that you meant benefit of the doubt that he in fact had felt the pulse. Is that right?
That's correct.
Okay. And when you said that in these types of procedures anything can happen, what did you mean by that? You were talking about over-sedation with Ativan, or when Mr. Flanagan was talking about flumazenil, and when you were referencing the endotracheal tube, you said you need to be prepared for that because anything can happen. What did you mean by that?
For sure. I can explain. When we think of using a sedative or a narcotic, we think of our desired effect to achieve, but before that, we always have to think of what is the worst case scenario. So we have to always prepare for the worst case scenario before we even give the drug. Whatever the indication is, be it for a procedure, be it for insomnia, before even giving the drug to the patient, we prepare for the worst scenario. What is the worst scenario? Propofol could cause severe lung collapse, respiratory collapse, breathing collapse, and it could cause cardiovascular collapse. And propofol does not have an antidote. So we had to prepare for the worst before we even administered it. And that's why we took great care in getting all the personnel, all the equipment ready inside the room, in the proper room, before we even start administering it.
Okay, so you're prepared for any consequences?
Yes, it is a must.
Okay, thank you. Nothing further, Your Honor.
Mr. Walkman, thank you. Mr. Flanagan, Reed Croft, please. In your familiarity with propofol,
Could you define familiarity?
well, you're knowledgeable in the drug and you've used it personally, haven't you?
I have used it with assistance from the anesthesiologist.
So you've never used it just on your own?
Never.
But whenever you've used it, it's always been in association with a procedure. Is that correct?
That's correct.
Okay. Now, propofol is used for drugs other than when a procedure is being used. Correct?
Possibly.
When you're talking about a procedure, you're talking about shocking somebody, cutting them open, or doing some kind of manipulation of their body that could be painful. Is that correct?
Could be painful. One nice aspect of propofol is it induces total amnesia. So, because we would not want a patient to remember how painful it is when the current passed through their body, through their heart, we wouldn't really want them to remember about that incident when they wake up. So, propofol does produce that nice amnesia effect.
And when you're talking about using propofol in conjunction with the procedure, would that be then referred to as procedural sedation?
Yes, it can be.
Okay. Are you familiar with a term called conscious sedation?
Yes.
And that's different than procedural sedation, isn't it?
Sedation for a procedure, that's all what it meant. It does not mean the level. So conscious sedations versus general anesthesia versus MAC and things like that. Rather than to say procedural sedation, we wouldn't still know what sedation level it is because there are many, many kinds of procedures which requires different kind of levels of sedation.
Okay. Now, when you're using propofol for procedural sedation, it means there's a procedure that's being used for, correct?
Yes.
And the recommendation is that the person doing the procedure shouldn't be in charge of propofol.
No.
You said,
I disagree with your statement.
so the person doing the procedure can also be in charge of the propofol?
Let me clarify because I am not sure I understand your question.
Well, if you were shocking somebody's heart to get the rhythm back, that's a procedure.
Yes, I would be in charge of the procedure. The anesthesiologist would be in charge of the propofol part.
Okay. But, and so you divide the responsibility. One person's doing the procedure, the other one's doing the propofol.
That's correct.
But you don't really have anything to divide up when there's no procedure being done, do you?
I don't use propofol when there's no procedure being done.
Okay, because you've never practiced outside a hospital, have you?
I do practice outside of the hospital. I have outpatient clinic. I don't use propofol in the outpatient setting. And even in the inpatient setting, I pointed it out to you that I only have it used in the ICU or the procedure rooms.
Okay, so you're only using propofol when you're doing a procedure.
Yes, sir.
Okay. And I take it have you ever heard of propofol being used as a pre-med for surgery?
Sure. Yes.
They use it as a pre-med to sedate the patient, don't they?
In the inpatient setting, in the appropriate room, yes.
And when they use it as a pre-med, they use a lot less than they use in a procedure, don't they?
Depending on what they're premedicating the patient for. What do you mean by a lot less? I'm not sure I follow.
Okay, well, if we take it to numbers, when you're doing a procedure, hypothetically, you got a patient, Jackson size, 135 pounds, about 60 kilograms. How much propofol would you use?
I would leave it to the anesthesiologist, but what I know is it depends on a number of factors, not just the size of patient. Size of patient is a good starting point, but do we use it in combination with some other drugs? Sometimes propofol is not used by itself. It's sometimes used with other sedatives such as, benzodiazepine. So if you use it with other sedatives, you can use a lower dose, 50 to 100 microgram per kilogram per minute. If you use it by itself and it is a primary agent, you can use it a little bit higher dose, 100, 150 microgram per kilogram per minute. And again, they have these small boluses, and they repeat these boluses every 10 seconds as they monitor up to the point that the anesthesiologist assess and felt that we have achieved the desired effect. So,
I'm not sure I understood all that. Let me try and put it in a term that maybe I could understand. Would you use 1 milligram per kilogram of body weight as a starting point?
I think microgram per kilogram per minute. 50 to 100 microgram. Microgram is 10 to the minus 6. So you're talking about milligram. That's 10 to the minus 3. So it's 1,000 of a milligram.
Dr. Cooper, who was here a little while ago,
a procedure room. I've never heard of propofol being used outside of the hospital.
you've never heard of a dentist using it.
I've never heard of... Could you repeat the question?
You've never heard of a dentist using propofol.
Did you mention somebody's name? Who used propofol?
A dentist.
Any dentist.
Any dentist.
I did not ask what dentists use, and they certainly did not use propofol on me during my dental procedures.
What procedure did you have?
I'm sustaining the objection. But the question really, Dr. Wynn, is not your personal experience, is if you're aware of propofol being used by dentists in dental offices outside of the hospital setting.
I am not aware of that, and I don't ask dentists what they use. I am more interested in what they use on me only.
I can see why that would be your major concern. How about gastroenterologists? Do they use on the scope?
I'll rule the objection if you know, in view of your experience.
I don't ask what GI doctors use for their procedures. I'm not interested in knowing what they use for their procedures.
Okay, well, you just never used it outside the hospital.
Correct. I never used it outside of the hospital. I never used it inside the hospital, outside of an ICU room or procedure room.
Okay. Thank you. Nothing further.
Flanagan, thank you. Mr. Walden, anything further? Your rep?
Dr. Wayne, have you ever heard of propofol being used in someone's bedroom in their own private residence?
That would be a first. No, I've never heard of such a thing.
Thank you. Nothing further.
Recross, Mr. Flanagan? Thank you. May Dr. Nguyen step down subject to recall, Mr. Walgren?
Yes, Your Honor.
Mr. Flanagan? May Dr. Nguyen step down subject to recall?
Yes, Your Honor.
Thank you. Dr. Nguyen, thank you for your testimony. Please don't discuss your testimony and the facts of the case with any other witnesses until we finish the trial. And while you may step down and leave, you are to remain on call, and that means you're subject to recall until the end of the trial. Is that acceptable?
Yes, Judge.
Thank you.
Thank you.
You're welcome. Mr. Walgren, Ms. Brazil.
Thank you. We'll call Dr. Joanne Prashad. And while Ms. Prashad is coming in, Your Honor, due to the mistake I had made on the bone chart, I had a corrected one made. I've shown it to Mr. Chernoff. I'd like to substitute People's 52 that had the incorrect bone time, 3:38 instead of 3:58, and substitute it for a corrected version.
Is that acceptable, Mr. Chernoff? It is. Thank you. 52 is substituted.
Thank you, Your Honor.
Thank you.
Please raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please be seated. Please state your name for the record. Spell your first and last names.
Joanne Bednarz Prashad, Joannne Bednarz Prashad.
Dr. Prashad, good afternoon. Let me provide you with some information and instructions which I give to every witness in every case. The first, please sit back and relax. The second, please speak in a loud voice. And that way all of us can hear you. The third, if you are called upon to provide an answer which can be answered yes or no, use those terms rather than slang which can be confusing. And the last, please wait until you hear an entire question before you respond. In our daily lives, many of us are used to talking over each other because we think we know what the question is. But in a courtroom, it's important to have the entire question first and then a response thereafter. Is that all acceptable? Yeah. Thanks. Ms. Brazil, direct.
Thank you, Your Honor. Good afternoon.
Good afternoon.
Please tell us what you do for a living.
I'm an internal medicine physician at Memorial Hermann Hospital in Houston, Texas.
How long have you been a practicing physician?
9 years.
What did you do before you were a physician?
I was a professor of microbiology at the medical school in Houston.
Do you work in a clinical setting or specifically and strictly in a hospital setting?
I'm a hospital-based physician. I take care of acute and critically ill patients in the hospital.
Dr. Prashad, on June 25th of 2009, were you working in the pre-op clinic at the Hermann Hospital in Houston, Texas?
Yes.
Did you have a reason to get in touch with a gentleman named Dr. Conrad Murray?
Yes, I did.
Would you please describe for us the circumstances which required you to reach Dr. Murray?
Yes. As a hospital-based physician, I'm sometimes called to come and help evaluate a patient who may be coming for surgery. And I was called to the pre-op clinic to evaluate a patient to make sure he was ready from a medical standpoint to have his surgery. And the patient had a history of peripheral vascular disease. And the question that I was called to help understand was a question that was between the surgeons, the anesthesiologist, and me, and that is, is the patient ready for surgery?
And Dr. Prashad, the starting point for your inquiry into the readiness of this patient to proceed with surgery would be what? Reviewing the charts?
Yes, of course, seeing the patient, taking the history, doing a physical exam, and understanding the patient's prior history, and then reviewing the charts of any prior admission.
Did the patient advise you that he or she had recently had a procedure and that procedure was performed by Dr. Conrad Murray?
Yes, he did.
Did the patient advise you that he was taking medication?
Yes, a part of the pre-op evaluation is to find out what the patient's past history is and what medicines they're taking. In this case, the patient was taking some medicines that were of concern to the surgeons and the anesthesiologist.
Why was it a concern?
Because the patient had peripheral vascular disease, he was on a medication called Plavix, and that was the concern at that time.
And how did the concern with the patient's existing medical condition and the prescription medication that he was taking, how did that interact with your concern about the procedure that he was about to undertake in your hospital?
The patient had an open wound on his leg and needed surgery to debride the wound, which was a deep wound, went to the bone, and so would be facing surgery that would be involve a lot of carotting and digging into the bone to get rid of any necrotic tissue. And because of that, there would be the expectation that there would be additional bleeding from the wound. And the patient being on a medication like Plavix, that's what caused the question. Can the patient continue to take the medication or not?
And the concern arose between yourself, the physician in charge of evaluating the preoperative condition of the patient, and the patient's anesthesiologist and the surgeon, correct?
That's right.
Explain the anesthesiologist's role in all of this, please.
The anesthesiologist is the person who has to determine whether or not the patient can tolerate the anesthesia. Can the patient tolerate being put to sleep and intubated, and then have the surgeons come in and do the surgery? And so their concern is if there is extra bleeding during the surgery, they want to know if that's going to be a risk. Is there any way to avoid that?
So what was the next step that you took in order to fulfill your duties to determine the patient's readiness for surgery?
I learned from the patient that he had a stent placed in the arteries of his leg. And
I'm sorry to interrupt you, but describe what a stent is, please.
Oh, I'm sorry. A stent is a device that helps to keep a blood vessel open. And they're commonly used in arteries of the heart, sometimes in the arteries of the periphery, especially in the legs.
And so determining that this patient had a stent in his leg, you learned of his medical history, and what steps did you take to obtain further information regarding his readiness for surgery?
I asked the patient when the stents were placed, and they had been placed about 4.5 months ago. And then looking over his list of medicines, I saw that he was taking Plavix. And then the question then arises, is it safe to stop the Plavix or not? And at that point, the length of time that a patient usually stays on Plavix is about 6 months after the stent is placed. Plavix is an antiplatelet medicine that's designed to reduce the risk that the platelets will cause a clot in the stent. So I asked the patient who his cardiologist was, and he gave me the name and phone number, and then I called Dr. Murray's office.
And when you called Dr. Murray's office, what were you attempting to achieve?
I wanted to ask Dr. Murray his opinion about this particular patient and whether or not I could tell the patient it would be safe for him to stop the Plavix and have the surgery.
And when you called Dr. Murray's office from the telephone number given to you by the patient, what information did you obtain? Were you able to speak with Dr. Murray?
I called Dr. Murray's office and was given a second phone number, and so I called that number and it went to an answering machine. Then I called back to the initial clinic number because the patient was in my clinic. We needed the answer to the information, and I asked for any other way to reach Dr. Murray, and I was given a second phone number.
Now let's just backing up for a moment. It appears from your recitation of your work with this patient that obtaining accurate medical information was very important to the determination as to whether this patient would be able to have surgery that day or not. Is that correct?
That's correct.
Are you taught in medical school the importance of charting information regarding a patient?
Yes.
Is it something that you yourself consider to be important?
I need the whole question first. Ask the whole question.
Is that something that you yourself as a physician consider to be important?
Not relevant. It's overall. You may answer.
Yes, I do.
And why is that?
It provides me as well as other caregivers for the patient to know what the previous care of the patient had been, what the outcome of various procedures, medications, treatments had been. And without that, it's difficult. The patients sometimes don't know the details of their medications or their procedures. They know the outcome, but not necessarily the specifics of what happened.
So you make your second attempt to reach Dr. Murray, and are you successful at the second number that you have been given?
Yes, yes.
So you dialed up the number, and what happened next?
The phone was answered. I identified myself as Dr. Prashad at Herman Hospital and asked if I was speaking with Dr. Murray, and I believe he said yes, he was. I explained the reason for my call and told him that I wanted to know if this particular patient needed to continue his Plavix or if we could successfully stop it for the surgery.
And you, of course, advised Dr. Murray of the procedure that you were about to provide to this patient, correct?
Yes, yes.
So he had full details as to why you were seeking the information?
Yes.
And once you described the situation to Dr. Murray, what, if anything, was his response?
Dr. Murray was very clear and stated very clearly that the patient needed to continue the Plavix. He hadn't fulfilled the 6 months of the treatment with this medication, and that it would be better to postpone the surgery and wait for the 6 months period to finish before taking him to surgery, taking him off of Plavix.
Did Dr. Murray recall for you the proper dosage that his patient had been taking?
Yes.
And he properly advised you as to the time frame that this patient needed to continue taking this medication related to the procedure performed some months earlier by Dr. Murray. Is that correct?
That's correct.
Did it strike you as anything unusual that Dr. Murray, just upon your phone call, it was in the morning, correct?
Yes, I believe it was about 12 o'clock my time.
Did it strike you as unusual at all that you called this physician out of the blue to inquire about a patient and a procedure, and he was able to provide you with the answer so readily?
Yes, it was.
Why is that?
Oftentimes, when a physician is called, they may say, well, I'm not at my office, or I'm not familiar with that patient, or I haven't reviewed the chart for a while, let me call you back. But in this case, Dr. Murray was very clear about the treatment and the need for the continuation of this medication. He was very clear about it.
He provided you with...
You said 12 o'clock your time. In Central Time? In Houston?
It was in the summer, so it would be daylight saving Central Time.
Yes, and just to clear that up, thank you, Your Honor. When you made this phone call, you were situated in Houston, correct?
Yes.
And you were calling Dr. Murray wherever he may have been when he answered his phone, correct?
That's correct.
Dr. Prashad, prior to testifying in court today, did you have an opportunity to review telephone records that contained the date and time of the call that you placed to Conrad Murray seeking the information about his patient as you've described for us?
Yes, I did.
I'd like to show you an exhibit that was previously marked as People's Exhibit 52. Your Honor, may I ask that the lights be dimmed, please?
If we may.
Dr. Pichard, if you would direct your attention to the overhead projector, do you recognize your telephone number on this chart? If so, there's a laser pointer right in front of you. If you could use it to indicate where you see your number. Would you read your number out loud, please?
Yes, 713-857-0134.
Is it
0124.
0124. And the time of that call, according to the telephone records, 10:20 a.m., correct?
Yes.
And you contacted Dr. Murray at the phone number 702-809-3747 that you had been provided by his clinic clerical staff member, correct?
That's correct.
And thank you, Your Honor. I'm ready to have the lights turned back up.
That's it.
Thank you. The conversation you had with Dr. Murray was fairly brief, correct?
Yes.
He provided you with the information that you needed.
Yes.
And did you then make the determination with the other surgical staff members that this patient's surgery should be postponed due to a possible adverse effect with the medication that he was currently taking for the stent procedure?
Yes.
Thank you, Dr. Prashad. I have no further questions.
Thank you. Counsel, if all right, I mean, that's up to you.
It won't be long, and I know what you're going to ask, but it'll be very
What
brief.
am I going to ask?
About the break. Yeah.
And what's the answer?
I hope your answer is you'll let me ask a couple of questions.
Thank you.
Okay.
Mr. Chernoff, did you say Memorial Houston?
Yes, Memorial Hermann Hospital in Houston, Texas.
I'm familiar with it. Welcome to L.A. One of the questions was asked of you was about Dr. Murray's, about medical records, I believe, about the importance of medical records. That was one of the questions that was asked by Ms. Brazil just a few minutes ago, right?
Yes.
You're not saying that Dr. Murray or his staff did not have medical records on this particular patient, are you?
No.
No. In fact, Dr. Prashad, would it be fair to say that a lot of times when you call a doctor, when they say, I've got to look at my records, I've got to go back to my office, they don't remember the patient. Is that fair to say?
Objection, call for speculation.
I'll overrule the objection. You may answer it. Goes to the witness's state of mind.
I'm sorry, which is...
A lot of times the doctor just doesn't remember the patient, doesn't remember the treatment.
That's correct.
But not Dr. Murray, right?
That's correct.
He knew the patient.
Yes.
He knew the treatment.
Yes.
He knew the protocol, the necessity to continue on with that medication.
Yes.
Would it be fair to say you were impressed?
That is true. I was impressed.
Thank you.
You're welcome.
Chernoff, thank you. Redirect, Ms. Brazil?
No, thank you, Your Honor.
Thank you. May Dr. Prashad be excused. Ms. Brazil?
Yes, thank you.
Chernoff?
Yes.
Thank you. Dr. Prashad, if you just give us a moment, let's let the jury leave, but if you can just remain for one moment. I want to thank you for your testimony. Please don't discuss either your testimony or the facts of the case with any other witnesses until we finish the trial. And once the jurors leave, you may step down and you may leave. Thank you.
You're welcome.
As to the jurors, ladies and gentlemen, you'll be taking your mid-afternoon break at this time. Please remember all the instructions, written and verbal. Enjoy your break. We'll take about a 15 or 20-minute break, and we'll give you the buzz, and you can give us the buzz. Thank you. Please watch your step.
This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California. This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California. This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California. This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California. This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California. This is the courtroom audio feed from the Conrad Murray trial in Los Angeles, California.